All right, we're going to go ahead and get started. Thank you all for being here today. My name is Erin Dyer, and for the past year, I've had the honor of serving as the ambulatory chief resident for the internal medicine residency program. And today is the second installment in our chief resident grand round series. We had some great presentations last week, and then today I'll be kicking us off, speaking first, followed by Cosette champion. And without further ado, I'll go ahead and get started. So the title of my presentation today, is More Things We Do for No Reason, Opportunities to Practice High-Value Care. I have no disclosures. And so for an outline of what we're going to talk about today, I'm going to start by giving you some background information about high-value care, and then I'm going to be using a patient case to kind of serve as the backdrop for a conversation about 3 things we do for no reason. These are all common diagnostic tests that we order in the hospital, and I'm going to show you some of the data behind each test so we can think critically about when and how we should really be using these tests within the framework of high-value care. And then at the end, I'm going to give you some of my conclusions that I came to after preparing this presentation. And so starting with high-value care has these 3 pillars of quality, patient experience, and cost. And so the idea is that we want to provide the highest quality of care to our patients and thereby improve their health. We also want to optimize the patient experience and try to reduce any unnecessary harms or protect our patients from procedures or tests that aren't necessary. And then all the while, we also want to try to reduce costs to the healthcare system and minimize waste. And so with the idea of high-value care in mind, the American Board of Internal Medicine in 2012 started the Choosing Wisely initiative, which was a campaign that was intended to spark conversations about what tests and procedures are really needed versus those that are not. This was kind of the source of inspiration for many other national societies to start their own conversations about high-value care. And so, for example, the Society of Hospital Medicine has a series called Things We Do for No Reason, which was the inspiration behind my talk today. They really focus on practices that aren't really supported by evidence or things that have just become common practice, even though we have better alternatives available. And then along the same lines, the American College of Physicians also has their own high-value care initiative. And so as a part of the Choosing Wisely campaign, in 2014, the ABIM conducted a study or survey of about 600 physicians across the country. And they were really trying to better understand what are the barriers to high-value care, what are some of the reasons that these physicians are ordering tests and procedures that they themselves think are unnecessary. And you can see some of the major reasons on the slide here. And so starting at the top, more than half of physicians reported that they were concerned about the possibility of malpractice. 30% or so said either they just wanted to be safe or they wanted some more information to reassure them. And then around 20-something% said that the reasons were a little more patient-driven. So either patients were insisting on the test or they just wanted to keep their patients happy. And I think a lot of us can probably identify with some of these pressures. We probably felt some of these feelings in our own clinical decision-making. And so speaking of our own clinical practice, I mentioned that we're going to use a clinical case to kind of serve as the framework of this presentation today. And so I want to introduce you to Mr. Jones. He is 72 years old. He has a history of COPD, hypertension, CKD3, and BPH. And he comes to the emergency department with 2 days of worsening dyspnea on exertion and sputum production. And in the emergency department, he has a new oxygen requirement. So at this time, I'm going to ask for a show of hands. How many of you would order a respiratory pathogen panel for Mr. Jones? Raise your hand. Okay. How many would not? Okay. And then many undecided people. I feel pretty certain that if Mr. Jones came to our emergency department, he would get a respiratory pathogen panel done. So this is the first thing that we do for no reason that we're going to talk about. Routine respiratory pathogen panels for ED and hospitalized patients. I think we've all become increasingly familiar with the respiratory pathogen panel in the last few years following the COVID pandemic. Most respiratory pathogen panels test for a long list of respiratory viruses. You can see some of them here on the screen. And they also test for a couple of bacteria that are known to cause respiratory illness. And so talking about the test itself with its pros and cons, we know that it's a really good test. So for example, the BioFire RVP has a sensitivity of 97% and a specificity of 99%. We know that these tests can be really helpful for either resolving diagnostic uncertainty or confirming our suspicions. And then they also open up the possibility of pathogen-directed treatment. So thinking about things like influenza or COVID-19, we can choose pathogen-directed treatment based on the results of the test. And then I think some people would argue that the results of an RVP can have an effect on how we prescribe antibiotics. So whether it's providing more targeted or narrow spectrum antibiotics or just foregoing that course of antibiotics altogether based on the results of the RVP. And then there's also the thought that by prescribing fewer antibiotics or more targeted antibiotics, maybe we can combat antibiotic resistance. I'm going to talk more about this question in a few minutes, so keep that in mind. But first, I want to talk about some of the cons of the test. So there are some inherent flaws with the RVP. We know that they can detect genetic material for about 2 to 3 weeks at a time. So a positive RVP doesn't always indicate a true infection. We also know that they can't rule out bacterial infection. So just because you have an RVP that's positive for rhinovirus, that doesn't mean you can't also have a superimposed bacterial pneumonia. And then speaking about cost, the RVP is on the range of $100 to $200. And then for comparison, the flu, COVID, RSV swab is a little less expensive at $40 to $60. So I mentioned the question of whether the RVP can affect how we prescribe antibiotics. And I have a couple of RCTs to show you that ask the same question. The first, this was a randomized controlled trial done with 1,000 patients seen in the emergency room. They either had symptoms of a respiratory infection, fever, chest pain, or poor general condition. And all of the patients in the study got an RVP, and then the clinician was randomized either to get the results within 24 hours or after 7 days. And so looking at their results here, so they had multiple different outcomes, including length of hospital stay, the number of days on antibiotics, the number of patients who received antibiotics, and then looking down at secondary outcomes, ICU admissions, 30-day mortality. And all in all, they didn't find any statistically significant differences between the two groups. So these authors concluded that they didn't think that the results of the RVP really had a significant effect on how clinicians were prescribing antibiotics. But here's another RCT. This one was 720 patients who were seen in the ED or admitted to a medical ward in the UK. They had either a respiratory illness or fever for less than 7 days. And then the patients were randomized either to get an RVP or to routine clinical care. And about almost half of the patients in that routine clinical care group also got an RVP. So let's look at their results. They looked at some of the same outcomes, starting with patients who received antibiotics. Essentially was the same between the two groups, 84 versus 83%. The mean duration of antibiotics was also not statistically different. But when you look specifically at the number of patients who got either a single dose or less than 48 hours of antibiotics, they found that there was a statistically higher percentage of patients in the RVP group who got those short courses of antibiotics. And then looking at hospital stay was also shorter by about a day in the RVP group. They did a subgroup analysis looking specifically at patients with asthma and COPD and found similar results. So patients were more likely to either get a single dose or less than 48 hours of antibiotics in the RVP group. Their length of hospital stay was shorter, and their total duration of antibiotics was also shorter. So they concluded that, maybe in these certain populations, there was some effect of the RVP on how we prescribe antibiotics. So at this point, I want to give you what I think about the test. And so I'm going to use this valuometer for the rest of the talk to talk about the cost, the harm, and the benefit of each of these tests. And so I think for the RVP, starting with cost, it is pretty low. Granted, it's more expensive than doing the flu test or flu RSV COVID test, but overall, compared to some of the other things we order, it's pretty inexpensive. The harm is pretty much non-existent. And I think the benefit can be substantial. And so I'm going to try to answer the question of when should we order the RVP? Well, the IDSA says that they think it's probably the most helpful in patients who have intermediate pretest probability and intermediate disease severity. And I take that to mean in patients where you have some diagnostic uncertainty and if it might change your management. Specifically, I'm thinking about immunocompromised or critically ill patients where we have different treatment guidelines. So for example, immunocompromised patients with RSV, we would give them ribavirin. I think the way that my clinical practice might change after having looked at some of this data is that I think we're probably doing too many of the full RPPs, and maybe we could do more just flu, COVID, and RSV testing. Those are the viruses that we worry the most about during respiratory viral season, and the ones where the test might actually change our management. So moving on to the next step in Mr. Jones' hospitalization. So he gets admitted to the hospital and he gets treated for a COPD exacerbation, but on hospital day 3, his creatinine is noted to have risen to 1.9 from 1.4 on admission. So again, I'm going to ask for a show of hands. Would you order a renal ultrasound to work up Mr. Jones' AKI? Who says yes? Who says no? Okay. All right, so this is the second thing we do for no reason, which is renal ultrasound in acute kidney injury. So talking about AKIs happen in about 10% of hospitalized patients. The most common cause is acute tubular necrosis. It makes up almost half of AKIs. And obstruction is the cause in about 10%. We know that obstruction is more common in kids than adults because of congenital abnormalities, more common in males than females because of prostate enlargement, more common in transplanted than native kidneys, and then more common in patients who have a history of stones or a bulky abdominal malignancy that would predispose them to extrinsic compression. And so talking about the test itself, we use the renal ultrasound to evaluate for hydronephrosis as a marker of urinary tract obstruction. It's generally a safe and non-invasive test, and it's pretty good. The sensitivity is 90%, specificity is 84%. The cost is somewhere on the range of $200 to $800. But in the end, hydronephrosis is only seen on about 1 to 10% of renal ultrasounds that are done for AKI, which has led some people to think that it's a pretty low yield test and has landed it on this list of things we do for no reason. So let's look at some of the data. So this was a retrospective study of patients who had a renal ultrasound done for AKI. The authors basically used this sample population to create a model, come up with a kind of a scoring system to categorize patients as either low, medium, or high risk for hydronephrosis. And this is what they found. So among patients who were found to have hydronephrosis on their renal ultrasound, they were more likely to have a prior history of hydronephrosis, abdominal or pelvic cancer, recurrent UTIs, a single functional kidney, neurogenic bladder, or to present with hematuria. And so based on these results, they created this scoring system and then validated it in a group of about 800 patients. They found that around 10% of the patients in this population had hydronephrosis on their ultrasound, which they commented was actually probably an overestimate of the real prevalence of hydro in patients with AKI, simply because they were only looking at patients who had an ultrasound done, and there were probably many other patients where the suspicion for hydro was low, and so the ultrasound wasn't performed. But regardless, they found this 10% had hydro, and about 3% had hydro that required intervention, which they defined as either needing a stent placed or nephrostomy tubes. And so you can see on the right side here, the low, medium, and high risk groups, and the prevalence of hydronephrosis in each of those groups. In the low risk group, the number needed to screen to find one case of hydronephrosis was 32, while the number needed to screen to find one case of hydronephrosis requiring intervention was 223. This model has been validated in several follow-up studies, but I don't think it's something that really ever has made its way into our common clinical practice. It's not something that I ever saw in training. And so getting back to the valuometer, starting with cost for the renal ultrasound, obviously more expensive than the RPP was, but still not prohibitively expensive. Harm, again, is pretty low. And the benefit, I would say, is somewhere in the mid-range, modest, depending on the patient. So let's try to answer the question of when should we get the renal ultrasound. So I think it really depends on your patient's risk factors. So if they have a history of BPH, prostate cancer, urologic surgery, malignancy, history of stones, if they're presenting with gross hematuria or abdominal or flank pain, if they have neurogenic bladder, I think those are all very good reasons to get the renal ultrasound. And then of course there's the catch-all category of the AKI is not getting better, we've done other things to try to figure out what's causing it, and we don't have any answers. That's also a valid reason to go ahead and get it. And then I would encourage you, if you're concerned about lower urinary tract obstruction, try to remember to get the bladder scan first. That might get you the answer that you need before you actually proceed with a formal imaging study. So I'll move on to the last phase of Mr. Jones' hospitalization. His AKI has been getting better, but he's quite debilitated from this hospitalization, and he's waiting on acceptance to a skilled nursing facility. Nursing tells you that his sleep has been pretty poor because he has a noisy roommate. And then on morning rounds, he's difficult to arouse. He's able to state his name, but he quickly drifts back off to sleep. So a show of hands, how many of you would order a head CT to work up Mr. Jones' altered mental status? Anyone? Okay. Who would not? Okay. All right, so the last thing we do for no reason that we'll talk about is neuroimaging for hospitalized patients with delirium. So delirium happens in anywhere from 30 to 60% of hospitalized patients. We know that it's associated with increased mortality and increased length of hospital stay. And then specifically when we're talking about acute stroke, because when we're ordering this head CT to evaluate delirium, really what we're looking for is stroke. And the incidence of delirium in patients with acute stroke is somewhere in the range of 13 to 48%. We know that patients who have acute stroke are more likely to have delirium if they are of older age, if they have a hemorrhagic stroke, extensive motor impairment, if there's pre-existing dementia, if they have a concomitant metabolic disturbance or infection. And then speaking about the test itself, so the head CT averages around $1,300. There's of course the risk that comes from radiation exposure with the test. And then talking about the test characteristics, sensitivity of the head CT for acute stroke is only 26%. Specificity is 98%, but I think I myself was surprised by how low the sensitivity was. So let's look at some of the data. So this was a retrospective study from Australia of 200 patients on a delirium unit who had head CTs performed. And out of those patients, about 14% had abnormal findings on their CT that the authors said explained their delirium. And looking at the results, so the patients who had abnormal findings on their CT were statistically more likely to have presented with new focal neurologic deficits, with a deterioration in their consciousness level, and were more likely to have had recent falls. Here's another study, again a retrospective study, of 220 hospitalized patients who had a head CT done for delirium or altered mental status that developed more than 24 hours after admission. Interestingly, they excluded patients with new neurologic deficits, falls, or head trauma. So they were really trying to hone in on that lower risk population. And among those patients, they found only 2.7% had abnormal CT findings, so 6 out of 220. And half of those patients who had an abnormal CT were on anticoagulation. So where do we put the head CT on the valuometer? Cost is substantially higher compared to the other tests we've talked about so far. Harm is still overall pretty low, but of course there's the risk of radiation exposure. And then the benefit, I think, is probably pretty minimal. So when should we get the head CT? Certainly if your patient has a new neurologic deficit, if they've had a recent fall, if they're on anticoagulation, those are all valid reasons. Other reasons would be if they're at risk for emboli, maybe they have a history of AFib, if they have a malignancy that puts them at risk for brain mets, or again, that kind of catch-all category of delirium's not getting better and we don't have a great explanation. And I would argue probably at that point, we're talking more about a brain MRI than a head CT. So I'm gonna move on to a couple of conclusions that I came to over the course of putting this presentation together. I really thought that when I picked my topic, I was going to gather all the data for these things we do for no reason and stand up here and tell you why you shouldn't be doing any of these things. And in reality, I think that a lot of these things do have valid reasons in the right context. I think what I would advocate for is that we all try our best to avoid the shotgun approach to ordering workup, and instead use an assessment of relevant risk factors to try to guide our decision making before we order tests and procedures. So think about what you're looking for with a certain test and whether your patient has risk factors for that thing. I would also encourage us all to think about what we're going to do with the results of a test before we actually order it. And if the results are not going to significantly change your management, maybe it's not worth doing the test. That's not always true, but it's something to consider. And finally, there are always exceptions to the rule, and you may miss something from time to time, and we all have to acknowledge that. So even though only 2.7% of patients who had low risk delirium had abnormal head CTs, that 2.7% still exists, and so it is possible that we're going to miss something from time to time. But I think we all need to be flexible and recognize that and be willing to broaden our differential, broaden our workup when things aren't adding up. So with that, I'm going to finish up and say thank you, Dr. Frazier and Dr. Chang and Dr. Forget, who have all been great mentors to me this year, and to my co-chiefs, you guys are the best. Thanks for all the laughs and supporting me, and thank you all for being here in the audience today.
All right, good morning, everyone. Oh, can you hear me? All right, good morning, everyone. My name is Cosette Champion, and I am one of the internal medicine chief residents for those of you who I haven't met. I'll be a cardiology fellow next year, and one of my interests within cardiology is cardio-obstetrics and women's cardiovascular disease. So this topic is near and dear to my heart, but hopefully I will convince y'all today that this is a topic that is also really important within the realm of internal medicine. I have no disclosures. But I do want to start with an audience participation question. What do you think when you hear the word preeclampsia? Be honest. A, yikes. Any takers? Okay, yeah. B, mag and deliver. All right. And C, this woman will be at a higher lifetime risk of cardiovascular disease, and I should think about this and account for it and follow up in the primary care clinic. All right, sweet. So while A is totally fair, and B, maybe some synapse from your step 1 brain is firing, I will hopefully convince you of C by the end of this talk. So we will define the hypertensive disorders of pregnancy, we will understand them as a risk factor for long-term cardiovascular disease, talk about implementing screening and follow-up in the primary care clinic, and finally, we'll touch on some inpatient or more acute presentations and initiating some of the workup and management. To be very clear, this is not designed to replace OBGYN training or suggest that you manage preeclampsia alone. With one very notable exception, our internal medicine residents generally don't deliver babies, and we should probably keep it that way. But I am hoping to demystify this a little bit, and most importantly, give you some things that some tools that you can use in the long-term care setting for these patients. So starting with a little bit of background, normal pregnancy physiology, the cardiac output increases by up to 50% during a normal pregnancy, mediated by an increase in heart rate and stroke volume, and is accompanied by a decrease in SVR and a decreased blood pressure. There is also some degree of insulin resistance in a normal pregnancy, which can help facilitate glucose delivery to the fetus, an increase in GFR, and an increase in the plasma volume. In contrast, the hypertensive disorders of pregnancy, we think of this as a spectrum from gestational hypertension to preeclampsia and eclampsia. But gestational hypertension is defined as a blood pressure of greater than 140 or diastolic greater than 110 that begins after 20 weeks gestation. So remember, normal pregnancy, blood pressure should decrease. Preeclampsia is the presence of proteinuria, or you can have preeclampsia without proteinuria if you have some features of end organ damage, so thrombocytopenia, elevated liver enzymes, an increase in your creatinine, pulmonary edema, or neurologic changes. And severe preeclampsia is systolic over 160 or a diastolic over 110. And then because this is something that begins after 20 weeks, you can also have someone with pre-existing hypertension who subsequently develops superimposed preeclampsia. Of note, preeclampsia can develop after delivery, and in this talk I'll use the hypertensive disorders of pregnancy to encompass gestational hypertension and preeclampsia of any severity. So preeclampsia complicates 2 to 8% of pregnancies globally and accounts for 16% of maternal deaths in high-income countries. And the incidence is on the rise, increasing 25% in the US between 1987 and 2004, possibly because of an increase in some of the risk factors, which we'll talk about subsequently. There are also notable differences in preeclampsia by race. In the United States, there are well-documented disparities in maternal morbidity and mortality, with mortality rates highest among Black women. And this trend is paralleled in preeclampsia, with highest rates among non-Hispanic Black women, followed by women who identify as American Indian or Alaska Native. And this is probably multifactorial, but may be related to socioeconomic factors or access to care. Regarding preeclampsia risk factors, this includes pre-existing conditions, things like diabetes, hypertension, or an elevated BMI, pregnancy factors like maternal age or nulliparity, or family history. And of note, many of these risk factors are the same risk factors for long-term cardiovascular disease. We'll touch briefly on the pathophysiology, which is pretty complex and still incompletely understood. But in addition to the risk factors, you have abnormal trophoblast invasion and artery remodeling, which eventually leads to placental hypoxia, and that causes an imbalance in angiogenic factors, leading to endothelial dysfunction and oxidative stress that ultimately mediates the end organ damage that we see in preeclampsia. There's also more of a pro-inflammatory state. So with that background, let's get into the associations with long-term cardiovascular risk. First, women with a history of hypertensive disorders of pregnancy are much more likely to develop chronic hypertension. This first study is a prospective study that followed women for a year postpartum with both ambulatory and in-office blood pressure monitoring, and found that by 1 year, 42% of women with a history of severe preeclampsia had developed persistent hypertension. And 17% of these were only detected by ambulatory blood pressure monitoring, meaning that if we're just seeing women in the clinic, we may be missing some of these cases. The next study, the Nurses' Health Study, looked at women over decades and found that those with a history of a hypertensive disorder of pregnancy had a 2.8-fold increased risk of developing hypertension, with a 4-fold risk in the first 5 years after pregnancy. And this study out of the Netherlands showed that women with a self-reported history of hypertension during pregnancy had, on average, about a 10 millimeter of mercury higher blood pressure that persisted over several decades, as well as more blood pressure lowering meds, or basically hypertension that warranted treatment with medication. And then for a number needed to screen among women ages 34 to 40, with a hypertensive disorder of pregnancy, you only needed to screen 9 patients to diagnose a new case of chronic hypertension versus 38 patients among women with a normotensive pregnancy. So what about the rest of the metabolic syndrome? The first is a retrospective study of 2.8 million women, showed a 2.4-fold increased risk of developing diabetes, and that was even after adjusting for things like BMI and gestational diabetes. And if you had both gestational diabetes and gestational hypertension, your risk of going on to develop diabetes was 16-fold higher. The second is a study out of Kenya that found a 3-fold increased risk of developing metabolic syndrome, which they defined as an elevated blood pressure, central obesity, high triglycerides, low HDL, and insulin resistance. Moving into some of the cardiovascular disease outcomes, this was a meta-analysis looking at preeclampsia and the risk of heart failure, and found a 3.6-fold increased risk of developing heart failure after preeclampsia, with the risk highest in the first 1 to 10 years after the pregnancy, and remaining elevated even after adjusting for some of the risk factors. Unfortunately, some of the older studies, like the ones in this analysis, didn't include a differentiation between HFrEF and HFpEF. They kind of just lumped it in as congestive heart failure. But newer studies show that preeclampsia can dispose to the entire spectrum of ejection fraction, from HFrEF to HFpEF. Many women with preeclampsia have abnormal diastolic parameters and some degree of concentric remodeling, both at the time of delivery as well as later on in life. And a recent study showed that preeclampsia was a risk factor for HFpEF hospitalization, but that this was being found in much younger women, a median age of diagnosis of 34, which is interesting. We generally think of HFpEF as a disease of older patients, but this is presenting in much younger patients with a history of preeclampsia. Next, coronary artery disease, a twofold increased risk, with an increased risk especially in the first year after pregnancy, and again, remaining elevated after adjusting for risk factors. Similarly in stroke, an increased risk after adjusting for risk factors. And then in this more recent study, they looked at cardiovascular disease, but really broke it up into gestational hypertension versus preeclampsia and found different associations. They found that women with a history of preeclampsia had a higher subsequent risk of coronary artery disease, while women with gestational hypertension had an increased risk of stroke. And so this is interesting. Generally, I think we kind of lump them all together or consider them to be a spectrum of diseases, but there may be interesting differences that could warrant future investigation. So the association between the hypertensive disorders of pregnancy and cardiovascular risk factors, as well as cardiovascular disease, is well described across dozens of studies and in really diverse populations. But unfortunately, a causal role is a little bit less clear. So one hypothesis is, the same risk factors that predispose women to develop preeclampsia are the exact same things that predispose people to develop cardiovascular disease. And while studies have shown that if you adjust for some of those risk factors, the risk persists, no study can adjust for everything. Another hypothesis is that maybe they share common physiologic processes. And finally, there is a hypothesis that preeclampsia induces some kind of long-lasting endothelial dysfunction that ultimately predisposes patients to go on to develop cardiovascular disease. So more research is obviously needed to elucidate this relationship further. Next, we'll talk about beyond the postpartum period and ultimately a role for the PCP in the management of these patients. So the immediate postpartum period is mostly managed by OBGYN. They recommend a goal blood pressure of less than 150/110, but there really aren't standard guidelines for medication management. They do recommend a blood pressure check 3 to 10 days postpartum, and then a 6-week comprehensive postpartum visit with a referral to a PCP if needed for ongoing blood pressure management. Unfortunately, there are very high rates of non-follow-up at both of these visits for a myriad of reasons. The American College of Gynecology describes the postpartum period as the 4th trimester and explains that this is a really critical period in setting the stage for a woman's long-term health outcomes, and so identifies this as a really important place to personalize care and provide patients the interventions that they need. So we saw that the first year postpartum, there are really high rates of persistent hypertension, suggesting that this is an important place to intervene, but there are a lot of barriers to postpartum care. First, the stress of the postpartum period. I hear having a newborn is kind of busy, and between sleep deprivation, pain, mood changes, there are really a lot of barriers to the postpartum woman getting the care she needs. Lack of child care can prohibit people from being able to make in-person appointments. Often there's no coordinated handoff between the OBGYN and the PCP describing the risk and the need for follow-up, even if that referral does get placed. And women are often unaware of the long-term risks, either because it wasn't communicated during the delivery admission, maybe it was, but it was just lost in the shuffle because of how busy things were, or maybe a provider wasn't aware of this long-term cardiovascular risk, and so thus hadn't appropriately counseled this woman. And then finally, there's the issue of loss of insurance. And so thinking about the care of postpartum patients, it's really important to think about the status of Medicaid expansion. 41 states have expanded Medicaid, including Missouri, and some of them that haven't fully expanded have extended postpartum care up to 12 months postpartum. So the ones in blue, which fortunately is most of them, cover women up to 12 months postpartum. In the states that haven't expanded, women lose care 60 days after delivery, and so in that period that is really high risk, and people really need to be closely followed, they potentially lose their access to health care. It's been demonstrated that expanding Medicaid does reduce maternal morbidity and mortality, and so I think any solution that's going to look at confronting the hypertensive disorders of pregnancy and the long-term outcomes is going to have to incorporate thinking about access to care. And there are some other innovative models that have looked at bridging some of these gaps or issues. The SNAP-HT trial was a feasibility study looking at self-blood pressure monitoring and medication management at home. So the usual care got their blood pressure checked by a midwife and their meds managed by their general practitioner, whereas the self-management group checked their blood pressure at home with a cuff at the same time every day, texted their results via smartphone, and got immediate feedback about med titration. And this was primarily a feasibility study, and most women completed the study, but they did see lower systolic blood pressure at 6 weeks in the self-management group, lower diastolic blood pressure that persisted even after they were no longer on treatment, and a shorter duration of treatment. So this suggests, not only could this potentially be feasible, but there may be benefits to really good blood pressure control up front. Some other innovative models to address these gaps in care: postpartum transition clinics to ensure a smooth handoff, telehealth clinics or home monitoring that can help obviate the need to come in if childcare is an issue, and finally, things like joint clinics that are staffed by cardiology and maternal fetal medicine together can often help to ensure that these women get the follow-up and the care that they need. So beyond the postpartum period, this management is often done by the PCP or by subspecialists, although many women are lost to follow-up as they're otherwise pretty young and healthy. And despite the well-documented risk, the guidelines are a little bit less clear on who and how to screen. The AHA says that, or considers that metabolic syndrome of pregnancy could be thought of as a failed physiologic stress test, basically showing us underlying or pre-existing disease, and really suggests that these women need to get plugged into care with their risk factors followed and managed. But what exactly does that mean? So the traditional models for ASCVD risk don't include things like hypertensive disorders of pregnancy, although that's changing a little bit. So these are the primary prevention guidelines, and they say that the risk discussion should consider these things like the risk enhancers that can be used to favor initiation or intensification of lipid-lowering therapy. And in that tiny text there right next to the red arrow, you can see conditions specific to women, which includes things like preeclampsia. So what would this look like practically? You may have a woman who's kind of borderline or intermediate risk, who may be just kind of on the border of where you would consider recommending statin initiation. Knowing that she has a history of preeclampsia may be enough to up-risk her that you would recommend, you're at an increased risk of cardiovascular disease, I would recommend starting a moderate intensity statin through shared decision-making. So the AHA recommends, and here's where y'all come in, that a provider meeting a patient later in her life take a detailed pregnancy history and specifically ask about things like gestational diabetes or hypertension during pregnancy. And here are some examples of ways that you might ask some of these questions. I think this is an opportunity for us because honestly, I generally don't ask my patients in the CO these questions, but I think it provides an opportunity to understand a patient's risk a little bit better by taking a few minutes to gather some of this information. And then what we do with that information, as Erin let us all know, we want to be thoughtful about the things that we're doing and not do things for no reason. Unfortunately, there aren't great recommendations for who and how often to screen and what is cost effective in terms of screening and follow-up. It would be great if there was a consensus statement between all of these organizations, but fortunately, they all agree on some of the same things, and they're the things that we're already pretty good at doing in the primary care clinic. So blood pressure management, including monitoring yearly, checking for lipids, fasting glucose, and addressing BMI yearly. Screening for diabetes, so women with a history of gestational diabetes need a diabetes screen 6 to 12 weeks postpartum and every 1 to 3 years thereafter. And given the increased risk for women with a history of hypertension during their pregnancy, it's probably reasonable to be thinking about doing this in these women as well. Of course, counseling on lifestyle modifications, diet, exercise, smoking cessation. And then I think maybe most importantly is just counseling on risk. As we said, many women don't know that this history predisposes them to a much higher risk of cardiovascular disease in the future. And so even just providing that information, I think, creates an opportunity to encourage lifestyle modifications at a time when it really may be able to impact their outcomes in the future. So an opportunity for education and some shared decision-making by empowering them with that information. Last but not least, we'll touch on a couple of acute presentations. Like I said, you probably won't be managing these patients alone, but you may see them present in the emergency room or the inpatient setting. And so I think it's important to be able to recognize. We'll touch on hypertension and other cardiovascular diseases. These are the obstetric emergencies algorithms from the American College of Gynecology. They put these together for sort of an ED setting for providers who don't generally take care of OB patients to be able to recognize these emergencies, and they're pretty great, so you can look them up. There's a lot to cover here, so we won't go through all of it, but I want to highlight a couple of things. First, ask the patient if they're pregnant or if they've been pregnant in the last 6 weeks. Remember, preeclampsia can present after pregnancy as well. The next thing I'll highlight If at any point the systolic blood pressure is over 160 or the diastolic is over 110, this constitutes preeclampsia with severe features, and it's considered a hypertensive emergency. So recheck the blood pressure in 15 minutes to confirm, but do not wait to initiate treatment. And I highlight this just because this is a different threshold than we would probably use in other patients to consider treatment of hypertensive emergency, so just something to be aware of. Regarding options for treatment of hypertension in the pregnant patient, you've got 3 options: IV labetalol, IV hydralazine, or PO nifedipine. Monitor, repeat the dosing as needed. Your target blood pressure is going to be 130 to 150 over 80 to 100. And importantly, if they've got preeclampsia, give some IV MAG for seizure prophylaxis. The loading dose is 4 to 6 grams. Monitor for MAG toxicity, especially if they've got decreased renal function. And finally, consult your friendly neighborhood maternal fetal medicine specialists. And then finally, we'll touch on a couple presentations of acute cardiovascular disease. Again, ask your patient if they are pregnant or were pregnant in the last year. Some of these conditions can present up to a year postpartum. And then modify your problem representation just a little bit. This may not be the classic patient that you think of presenting with an MI, but please don't exclude cardiovascular disease in these patients just because of this high risk. Red flags for cardiovascular disease, I think we're all pretty familiar with, but I wanted to highlight a couple of things to include in your differential. This will be things like an MI from a spontaneous coronary artery dissection, or peripartum cardiomyopathy, which is a form of systolic heart failure that can occur in the last month of pregnancy or the first several months postpartum. So just a few things to have on your differential when a patient in this demographic presents. And then finally, a note on treatment. So most medications don't have robust safety data for long-term use among pregnant and breastfeeding patients, but in a life-threatening emergency, you should not withhold an indicated medication or imaging study if it is otherwise indicated. Long-term, consult your cardiology colleagues, but in an acute or emergency setting, please don't withhold indicated meds or imaging. All right, so with that, we'll come back to our initial audience poll. What do you think when you hear the word preeclampsia? Anyone still yikes? Is still totally fair. B, MAG and deliver, yes, but also think about if they need blood pressure and blood pressure treatment and use one of our 3 preferred agents. And finally, any takers for C, this woman will have an elevated long-term cardiovascular risk. Great. All right, so our take-home points: gestational hypertension and preeclampsia are well-documented risk factors for future cardiovascular disease. So ask your patients about this when you meet them for the first time in the primary care clinic, and then use that history to guide your screening, your counseling about risk factor modification, and counseling about future cardiovascular risk. And finally, in the acute setting inpatient, ask about recent pregnancy, recognize some of these acute presentations, and don't withhold any indicated imaging or treatment. With that, I'd like to thank Dr. Lindley and Dr. Joint Maddox, my mentors in my cardio-OB research, and for their help in reviewing these slides, our fantastic PD, Dr. Chang, Dr. Frazier, my co-chiefs, and of course, our patients. These are my references, and I'm happy to take questions.
Erin and Cosette, those were great presentations. I think we have time for a few questions. Steve?
Great presentations, both of you guys. I have a question for Erin.
Okay.
So, totally agree that renal ultrasounds, when you're looking for obstruction, they're over-ordered, and we should really be thinking about how to tailor it. In renal world, we often get renal ultrasounds for other reasons: reversibility, chronicity, edema, things like that. Did you see any data about, instead of just obstruction or not, change in management?
So there was one study that I looked at that did comment on like other findings on the renal ultrasound, but I think in that acute setting, it's not really going to change your management. So maybe you see some kind of like, long-term effects, but I think probably in the acute setting, I don't know. Do you have any other thoughts?
I think in patients who have an unknown baseline or who have chronic kidney disease, and you get an ultrasound that shows a shriveled up kidney, the workup can essentially stop because you're not going to reverse something.
Sure.
Or sometimes in patients with a malignancy, if you suddenly see a larger kidney and you think of infiltrated diseases, I actually still think in the acute setting there is utility in it, although for very specific reasons.
Yeah.
I don't think we should just be paying or bring ultrasounds.
Right. No, I think that indication makes a lot of sense. I didn't think about that. Yeah. On renal ultrasound? Yeah. I think that's a great solution, a great way to kind of get around the problem of, needing a radiologist to interpret the test and the cost of the test. I think POCUS is becoming, more and more widely used, and I think is pretty good. I think, POCUS sonographers are pretty good at looking at the kidney and ruling out hydro. So I think that's a great option. Yeah.
So Cosette, what do you think are the biggest barriers to trying to develop, better screening and evaluation of women with peripartum cardiovascular disease? Because it seems like there are sort of significant gaps in our care and access to care.
Definitely. So I think a couple of different things. First, as you mentioned, Dr. Frazier, there are big gaps in care, especially in the postpartum period, for a lot of the reasons we talked about. So I think trying to structure the healthcare system in a way that makes care most accessible to our patients, if that means, options that include things like home monitoring or telehealth, if that means bringing all of the different teams that need to be involved in their care into one spot, like a jointly staffed clinic, I think that would be really impactful. And then I think a little bit more clear recommendations on exactly who and how we should be screening would be helpful as well, so that even if they're following up in the PCP office later, us knowing really well like who actually benefits from the screening and what exactly should I be doing would be helpful. And in order to develop that, I think studies as to which interventions really do improve these outcomes for women in the long term would be helpful to base some of those recommendations on. Yeah, so the question was, in trying to understand some of the mechanisms that predispose people to cardiovascular disease after a hypertensive disorder of pregnancy, especially in someone without the traditional risk factors. And that's a really good question, and to be honest, I'm not sure. I haven't seen a ton done yet, but I do think it is really interesting. Obviously, some component of it may be explained by people who have these pre-existing cardiovascular disease risk factors, but I do think genetic studies would be really interesting. I'm just not sure that study exists yet, but a good future direction.
For Cosette, maybe Erin can chime in too, for all this last year. Are there any programs set up where our OB/GYN colleagues can refer to PCP? Because I feel like we in the primary care clinic do a lot. We refer to OB for various obstetric and gynecologic issues, as well as like woman exams. But at least from my limited personal experience, in cases that I saw, I feel like there was very little going the opposite direction, where OB was sending patients to us because they had preeclampsia, because they had things that needed closer follow-up or that they should establish. So is there anything actually set up? Have you talked with some of the gynecologists?
I got a couple thoughts.
Yeah, so the question was about what the connection is between our primary care clinic and OB clinic. And I have seen a good number of patients referred from OB to our clinic, specifically because they're postpartum and, they have hypertension. I don't know that the referral is in the nature of like, oh, they have preeclampsia and they're at higher risk, for long-term cardiovascular effects. But I agree that I think the communication could probably be better. Instead of just, sending the patients to establish with a PCP, maybe giving a more clear reason about what we're really trying to manage. Anything else to add?
Anne-Marie, I saw your hand up, so if you have anything to add about this, go for it.
Yeah, well, or just, my name's Amber, I'm one of the general cardiology fellows. Regarding your question, Dr. Verma and Dr. Mahmoud are two of our cardiologists here at WashU, and both of them have fairly close connections and relationships with our maternal fetal medicine teams. So a fair amount of the time when we are, as general cardiology fellows, seeing patients who are admitted and have some cardiovascular problem, we'll commonly help them set up follow-up with either of them.
It does seem too high, and I'm not sure if there is any move to try and figure out if that should be lowered, or if that is, it seemed like that was more just the first couple of days postpartum is what they would want to see, but I didn't see, you know, in the up to the 6-week follow-up, other than in general, we want a normal blood pressure, like a 120/80, but you're absolutely right. And I think that brings up an interesting question, because these are, for the most part, otherwise pretty young, healthy women. I feel like if I saw a 31-year-old in my clinic with a blood pressure of 140 over something, you know, a lot of us, I think, would be hesitant to start a medication and would really just be like, let's really push the lifestyle factors first. But if there were any evidence to suggest that really kind of aggressively lowering the blood pressure, including with medications if needed, that would maybe change the way that we practice. But I think maybe in my own practice pattern or right now, I think a lot of us might be hesitant to start a medication in a younger patient. But that, you know, understanding that risk better, and if there really is a benefit to tighter blood pressure control, would be able to help change that. Yeah, that was an interesting one. I would be interested, you know, they followed women for, I believe, 6 months or a year afterward, and saw that there was a benefit to better home monitoring blood pressure control even after they were off meds. I'd be interested to see if that benefit persists even after that. So if we are really aggressive about intervening in that initial period, does that predispose them to lower risk of hypertension even like a couple of years out? So interested to see the follow-up there.
Thank you both.